There we go. Welcome, everyone. We're going to go ahead and get started. One of the unintended consequences of being back in person is you can never get people to stop talking, which is a good thing. I really appreciate everyone being here. I want to welcome everyone to our Grand Rounds, Department of Psychiatry Grand Rounds. I also want to welcome, we have, can't see this now. And this means, okay, yeah, let me get rid of this. I'm sorry, I'm trying to visualize. Yeah, we have 64 people online, so welcome to all of you online. Today, I am very pleased and honored to be able to introduce our guest speaker, who's one of our colleagues on the other side of town. We have today with us Dr. Paul Nestadt. Dr. Nestadt is the James Well Professor of Psychiatry at the Johns Hopkins School of Medicine and Public Health, where he serves as co-director of the Cross School Center for Suicide Prevention. As an inpatient psychiatrist attending on the Johns Hopkins Motivated Behavior Unit, he treats patients who suffer from comorbid substance disorders and other severe serious mental illness who require acute management. He also directs the Anxiety Disorders Clinic and works in the Esketamine Clinic at Hopkins. Dr. Nestadt is the chair of Maryland's Suicide Fatality Review Committee and is a nationally renowned expert on the practical risk factors for suicide, such as opioids and firearm access. He has written dozens of chapters for leading psychiatric and medical textbooks, over 60 peer-reviewed papers, and has spoken nationally and internationally on the topics of suicide risk and the role of firearms, opiates, and the limitations of screening. So please join me in welcoming Dr. Nestadt as he presents suicide, firearms, and use of extreme risk protective factors.
Thanks.
Well,
Thanks, everybody.
I have to say about the questions.
Oh, yeah. We were talking about maybe saving questions till the end, but if something's pressing, just yell. So, hey, I always feel awkward during introductions, but I should just say I'm sort of half clinician, half researcher, and I want to sort of talk to you more in the role of a clinician today, but I want to talk about some of the research behind suicide. So let's see what changes the slide here. So just real quick, I want to cover the epidemiology of firearm suicide. This is an audience that is very familiar with the epidemiology of suicide, but just briefly want to talk about firearm suicide and then talk about the role of gun access, lethal mean access specifically. And at the end, I want to talk about really the reason I came today, talk about extreme risk protection orders and a new tool that we're hoping to roll out at Maryland specifically to use them better. You guys already know suicide is a major cause of death in the US. It's been a problem for a long time. This sort of averages over the past several years, although suicide's been dropping with the introduction of COVID, raising as a cause of death, but it still remains the second leading cause of death for young people in America, and is the 11th or 12th cause, depending on the year you're talking about, for across the lifespan. The rates have been going up throughout the whole time I've been studying suicide. This figure, actually, I'm setting up the laser pointer work. This is just sort of condensing suicide rates over the second half of the 20th century. And you see it was kind of high after World War II. Around 1987, which was the year Prozac came out, we started to see a pretty steep decline in suicide rates. I don't know if it was related to Prozac or if that's just sort of an ecological fallacy, but we did see that drop until around the year 2000. And then in the early 21st century, we saw an increase in suicide rates. There was a steady increase for a very long time that was really unrelenting until around 2020, 2019, when we saw a little bit of a dip. And that was a little surprising because, of course, 2020 was a terrible year. And I give a whole talk on why that might have happened. But we did see this decrease that made a lot of us in the suicide world really excited, thinking maybe we turned around this inertia and this sort of momentum that suicide rates had. However, when the data came out in 2021, 2022, we saw an increase. In fact, this last year of data that's available from the CDC takes a while to get data out. The last year of data from 2022 showed the single highest year-over-year increase in suicide rate we'd ever seen, such that now the rate is highest that it's been since we've been keeping track, since World War II, basically. So it's not great news. Quick epidemiology of suicide. You guys already know suicide rates are much more common in men, even though women do attempt more often. We see higher suicide rates in indigenous populations and white populations. That's changing a little bit now. I want to just show you this figure for a second. This is suicide rates across the lifespan. Maybe it's a little too small for you who are here in person to see, but the solid line is the suicide rate across the lifespan of the general population. The other lines are stratifying by race and ethnicity, where there's differences. You see the highest rates around age 50 in general population. If this chart didn't condense over 65, we'd see that over 85, we see a particular increase in men that's higher than any other age. However, if you look at the suicide rates across the lifespan stratified by race and ethnicity, you see here in American Indian populations, indigenous populations, the rate is very much higher in the early teens, around 15, 16, 17, 18, 19. That is also the case in Black population, where we see the highest rate, again, like, 19, 20, higher than it gets into 50 or older. It's just a difference that we pay attention to, especially in Baltimore, where most of our population we're treating in the ER are young Black men. And so I sort of keep in mind, not that that's going to be the only factor for a clinical assessment, but the younger ages are higher risk as opposed to in the white population, which drives these general numbers, where we see the higher risk around age 50. I'm going to come back to that a little bit. I'm not going to list all the risk factors for suicide to a psychiatric audience, but I will say that I think of those risk factors as categorizable into chronic versus acute risk factors, and of course, into fixed risk factors we can't do anything about, and modifiable risk factors. So for instance, having a family history of suicide in your patient is not something you can change, or having a terminal illness or these demographic factors I just sort of went over. But there are things we can affect. We can address social isolation, we can address poverty, we can address psychiatric illness, which is arguably the biggest risk factor for completed suicide. And we can address access to legal means, which is what we'll talk about for all the rest of this talk. Suicide rates vary across the country. This is the general suicide rate in different states. You see sort of a suicide belt. These sort of more rural states with a darker shading have a higher rate. In Maryland, it's the same. The more rural areas in Maryland have a higher suicide rate in general. Just zooming in a little bit, this is Baltimore City. This is just from my own data. This is every suicide in Baltimore City over the past 15, 20 years. You see, of course, that every black dot is a death. But when you control for population density, you see sort of hot spots and cold spots for suicide, which, just like everything in Baltimore, reflect redlining, right? So we see the demographic differences. We see sort of less suicide rates in areas of the city that are more Black. You see the blue areas, whereas the red areas, like where we are now, are not only sort of at risk because of demographic issues, but also this is near the harbor, which is a place where people do attempt suicide, as you all know. And also there's a high density of liquor outlets and bars, which have been long correlated to suicide rate. So look, despite the suicide death rate being really high, in all these ways I described, and higher than it's ever been, the suicide attempt rate is still much, much, much higher, right? In this table, I just broke down between young people and adults. This is past year prevalence from surveys, so self-reported, with all the biases that come there. But you see, just looking at high schoolers, for instance, about this study says 18.8%. Actually, I should update. The YRBRS has come out again in 2022. And it's more like 21%, but a high proportion of high schoolers report that they seriously considered suicide in the past year. So 1 in 5, which makes a self-report of suicidal ideation, frankly, not very clinically useful. It's pretty ubiquitous. About 15% have made a plan in the past year. About 9% have attempted. This is all young people, but only about 11 in 100,000 die by suicide. Similar with less of a ratio in adults. A lot of people have ideation. A lot of people attempt. But relative to that, very few actually die, about 14 or 15 per 100,000. So put another way, if you have like 2.2 million attempts, some of which are hospitalizations in a given year, only about 50,000 deaths. So most attempts are survived. And that's important. And those are the people that we all meet, right? Those are the people we're working with. And I'm going to talk about them a little bit, but I'm mostly going to talk about the people that we don't meet that fall into this very thin slice of the pie. In thinking about that attempt versus completion, the first thing every med student is taught is about suicide is that there's this high rate of attempts in women and high rate of death in men, which is a weird paradox. To put some numbers to it, women do have about 2 or 3 times the attempt rate compared to men, but men make up about 80% of all suicide deaths, as I mentioned before. To understand that, there's a couple of things that go into it. There's a couple of cultural factors, but I think ultimately the best way to understand that difference is to look at the methods used, because the methods used really are what determines whether an attempt is survived or not. This is a study by Connor and Matt Miller's team up in Boston. That's a replication of a CDC study. It's been pretty consistent. If you look at this table with this laser pointer, you see this study took about 4 million suicide attempts that were recorded in the US. This is all CDC data. This was all the suicide attempts recorded from, I think it was about 2007 to 2015, something like that, about 7 or 8 years. About 4 million attempts, if you look at this total. And of those 4 million-ish attempts, there were about 300,000 deaths, which means that suicide attempts have a fatality rate of about 8%. Right. But if you stratify by method, as they did here, look at poisoning. So poisoning, which is overdose, whether we're talking about Tylenol or opiates or anything, poisoning is by far the most common method of attempt used in the United States and globally, for that matter. So more than half of these suicide attempts were by poisoning. And yet there were only 43,000 deaths. Right, there's a fatality rate of about 2%. This is good. So most people you've treated for suicide attempts have probably been from poisoning, and you've got to treat them because they were part of the 98% that survived. And we'll talk about what happens to them afterwards. But firearms, on the other hand, are only used in about 5% of the attempts. And yet they result in about 150,000 deaths because they're so fatal. So 90% of the time when a firearm is used in a suicide attempt, it results in death instead of a survived attempt. Actually, sometimes I'm talking to a clinical audience, I'll mention, this is also interesting when we look at physician suicide, which is an interesting subtopic. We can talk about it if you want. With physician suicide, there is still that difference between female and male attempt and death. Women physicians do attempt more than male physicians do not. But the difference is much, much smaller. The ratio is much smaller. And part of that has to do with the fact that physicians tend to not use guns as often. There's a study that I left as a revise and resubmit, never actually resubmitted, where we looked at what physicians use. Physicians do tend to use poisoning, overdose, and also cutting a lot more than the general population. And arguably, whether you're a man or a woman, as a physician, you know more about what drugs to take for fatality. You have access to more dangerous drugs. And the same goes to cutting, without getting too graphic. We kind of know how to make that fatal. And so that might be why that difference shrinks a lot. Whereas in the general population, men tend to use guns, and women tend to use overdose or hanging more often. So to put that another way, the suicides in the United States in general, the majority are firearms. Most suicides are firearms. Firearm suicides make up more than all other methods of suicide combined. So this is the 2021 data, but it's the same in 2022. About 55% of suicide deaths are by firearm, even though only 5 or 6% of the attempts are by firearm. In fact, I do gun policy research beyond suicide, but I always bring it back to suicide, not just because I'm a psychiatrist, but because most gun deaths in the US are suicides. They're not homicides. They're not mass shootings. Those things are terrible, but most gun deaths are suicides. So if we're trying to reduce gun deaths, this is the avenue to attempt. As I said, I'm not going to go through all the risk factors for suicide, but there are so many. It's so multifactorial. But if you look at all of these risk factors, this is from Keith Houghton's model. Whether it's about personality traits or having a psychiatric disorder, psychological stress, exposure to suicide in someone all those risk factors come together at this point when an attempt is made. And that attempt is made and either results in a suicide death or in a survived self-harm attempt. We'll talk about what happens to those folks in a second. And the only thing that distinguishes which side of that fork you end up on is whether the method that was used was likely to be a lethal method. And the choice of method, it turns out, really just comes down to the methods that are available to a person at that time that those suicidal thoughts start to take over, really. To understand that, I talk about something that a lot of lay people aren't as familiar with, but clinicians might already sort of be very familiar with this, which is the impulsivity of suicide. There is this sort of idea, so in movies and things like that people build up to suicidality. They have ideation for a while and they make an attempt. Sometimes clinicians even get that sense because the people that we treat are the ones that have had lots of suicidality. That's how they're coming to our attention long before. But in reality, most suicide attempts are come to pretty impulsively. I don't want to say all. This is not a homogeneous group. I'm an epidemiologist, so I'm averaging out. But they've done studies looking at suicide attempters. One that I like to cite a lot is Simon's study from 2001. This is a study where they took about 150 people who had attempted suicide in a serious enough way that they were hospitalized. And Simon's team interviewed these folks, essentially asking questions along the lines of, you might have been depressed for a while, thinking about suicide for a while. But at some point that ambivalence resolves and the decision's made to attempt suicide. How much time passed between that decision and action? And in those interviews, 87% of these folks said it was same day, within 24 hours. So 87% of them. 71% of them said within an hour. For a quarter of them, it was within 5 minutes. They decided to do it, and they did it. And when it's that quickly, when it's impulsive like that, people use what they have. If what they have in the bedside table at 2 a.m. when this resolution is made is Tylenol, that's what they'll use, and thankfully will survive 98% of the time. But if what's available to them in that moment is a gun, the likelihood of survival obviously is much, much, much slimmer. So who uses a gun for suicide? People that have guns. This is a little different than the map I showed you before. This map of the US is the firearm suicide rate specifically in the US. Again, darker is more. So you see states like Montana, Idaho, Alaska have very high firearm suicide rates. And on the right here is a map of the household gun ownership proportion in each state. So like, again, like Montana, 52% of houses have a gun. Alaska, 60%. They look very similar if like you cross your eyes and overlay them. There's been studies that looked at that a little bit more scientifically and found, maybe I won't go into so much detail because I don't have time for questions. I'll just say that areas that have high gun ownership in this country tend to have much higher suicide rates, firearm suicide rates, but also because so many of the suicides are firearm. That means their general suicide rates are higher too. This is particularly true in children. In children, if you compare high gun ownership areas of the country to low gun ownership areas, the child suicide rate triples, controlling for all the things you'd control for. On an individual level, Engelmeyer found that just having a gun in the house triples the rate of suicide in that house, likelihood of suicide. It's in some cases, depending on how you calculate it, it's a bigger risk factor than having depression. Danielle Steele-Smith did a really good study that found that in urban counties like ours, for each additional gun shop in the county, there's a 1% increase in suicides, like county controlling for other things. Actually, I should update this slide. I just had a study that came out myself about 3 weeks ago, where we looked at the density of gun shops in Maryland specifically, and found that the more dense gun shops are, census block by census block across the whole state, the more firearm suicides and actually suicides in general we see. There's no increase in non-firearm suicides, but there's not a replacement to non-firearm suicides. Sticking with youth for a second, NAPOP did a study in 2019. It's very straightforward. This figure, you probably can't see from there, but each of these dots is a state. They have the little letters in them. So like, here's Maryland right here. Here's North Dakota. Across the y-axis, across the x-axis, you see household gun ownership, and the y-axis is the youth suicide rate, the log. Just the more guns you have, the higher your youth suicide rate is. It's a pretty tight correlation. That's controlling for nothing. But the same group did a study where they made a multivariate model, controlling for all the things you want to control for, veteran status, access to mental health care, all those things, and found that for every 10% increase in household gun ownership, you'd see a 27% increase in the youth suicide rate state by state. So often when I'm talking to a lay audience, I'll get questions more about the general ideas behind suicide, as opposed to what we can do about it, which we'll talk about together later. And one myth that I've seen come up again and again is this idea that if I'm saying guns are the problem, if we just take away guns, won't people just find some other way? And this is a widely held idea. Matt Miller did a study where he surveyed people and he asked them, you know, if this is a general population survey, if someone was on the Golden Gate Bridge and they were somehow, you know, to die by suicide, and they were somehow thwarted, would they just find some other way? And most Americans, 3/4 of Americans said, yeah, most or all these people, if you stop them from jumping, they just find some other way. That's why it took so long to put up those barriers on the Golden Gate Bridge, right? Disbelief. Emmy Betts, who was a resident at Hopkins, now she's out in Colorado as an ER resident, ER doctor. She surveyed ER doctors and nurses and social workers, asking them similarly, if there was someone that was going to die by gun suicide, you take away the gun, would they find another way? And a little more than half of them said, yeah, they would just find another way. Important population, right? Because the folks in the ED are the ones that are evaluating someone that comes in and deciding whether they need to be hospitalized, sometimes involuntarily. If they think locking them up for a couple of days is not going to change anything, they're just going to go right back out and try, they're going to release people that are potentially very vulnerable, but they simply believe that. The reason Matt had used the Golden Gate Bridge is it's very well studied. The Golden Gate Bridge is a hotspot for suicide, as you all know. Stein did a study in the 70s looking at people that had been thwarted from jumping from the bridge. Actually found over 500 people like that had either survived the fall, about 1% of people survive, or had got caught on the scaffolding, or had been just like physically yanked off. They went there for suicide, but they didn't die. And he followed them for a median of 26 years, which is funding that I can't get today. But he followed them for a very long time. And over that time found that less than 5% of them went on to die by suicide. There was many studies like this. O'Donnell did this in the UK, in London. Looked at people that had jumped in front of the tube, the subway, right? Again, very likely to end in death, but you can fall between the tracks, can pass over you and survive. So O'Donnell found almost 100 people that had survived that attempt, followed them for a decade, and found that a little less than 10% of them went on to reattempt or die by suicide. There's a meta-analysis that was done that found, with all the studies like this, it's essentially about 6% of people that survive a serious attempt go on to die later. So the vast majority, 94% of people, if they don't die in that index attempt, they don't die. That's not nothing. Still 6% of people is a lot. And when you get someone that comes in after a suicide attempt, treat them, but it's 6%, 94% just keep on surviving. So if you can save them in that index attempt, you've saved them for more than just that week. So then what happens if we have a popular lethal method of suicide that we do make unavailable? So in the US, talking about guns, but in other countries, it's other things. In the UK for a long time, it was ovens. Coal gas ovens produced carbon monoxide, which obviously is poisonous. And it was a very popular method of suicide in the 20th century in the UK. I think Sylvia Plath, right? This is something that not everyone, but most people had an oven. And it was very easy to blow out the pilot light at that time. And then it was a very fatal method. So in the UK, they started phasing out carbon monoxide producing ovens, not because they wanted to prevent suicide, just for economic reasons. And over the course of that phase out, Kreitman's team followed the suicide rates in the UK, England, Scotland, and Wales over that time. And you see, this is the proportion of ovens that were still using carbon monoxide producing coal gas go down to nothing by 75. This is stratified by sex. In men, the carbon monoxide suicide rate went down, not to nothing. You could still use other things for carbon monoxide. At that time, carburetors in cars could be used, but it required a little bit of work and planning and time. You had to string a hose. Remember how impulsive suicides are. So there was very few people that actually did that. And there was not a replacement with other methods. This is non-carbon monoxide suicides, stay about the same. But because the carbon monoxide ones went down, the total suicide rate in men went down. In women, it's pretty similar. Carbon monoxide goes down, maybe a little bit of replacement to other methods, but not nearly enough to offset the lives saved. The total suicide rate goes down. Other countries, it's other things. In Sri Lanka, really any agricultural economy, people use pesticides or herbicides. So here, just as this figure is the suicide rate by method in Sri Lanka. This light blue line is suicide rate using poisoning, which as I said is very popular worldwide. This is hanging, this dark blue line, so sort of a very distant second as far as suicide rates. So similar to how we have guns, and then distant second here, and then other methods here. In the 80s, they banned some carcinogenic pesticides, didn't really have an effect on suicide, but they banned all the class 1 pesticides in 1995, the ones that people would overdose on and die. And most of you probably treated organophosphate poisoning. It's a terrible way to die. As soon as they banned those pesticides, the suicide rate by poisoning starts dropping as they're phased out throughout the country. Here's another pesticide banned here, starts dropping. There's maybe a very slight replacement to hanging, but overall, this had the effect of cutting the suicide rate almost in half in Sri Lanka. Back in the UK, paracetamol, Tylenol, over-the-counter headache medicine, was a very common method of suicide. And Parliament, in this case, actually, in order to reduce suicide rates, changed the rules around paracetamol and a couple other over-the-counter medicines, making it so that you could no longer buy like a tub of paracetamol. Like here, you can go to BJ's, get a whole bunch of Tylenol. There, you can only get 16 tablets in one bottle, or if you go to a specialty pharmacy, you can get 32 tablets. So if you want enough to overdose on, you have to kind of go to multiple pharmacies. And generally in your medicine cabinet at home, there's not as many lying around as we would have here. When they passed those rules, there's a decrease in UK poisoning suicides by 22%. Let me stop and go back and talk about these numbers. I'm like 22% or like cutting. When I showed you that figure of like the suicide rate in the US and how it was going up, and then we saw this little dip in 2020, it was very exciting. That dip was like 3%. We saw like a 3% decrease and then like a 6% increase. Like that's how suicide rates generally move year to year. So we're talking about a 22% drop or cutting suicides in half. It's really big. It doesn't seem like a lot, but we're talking about many, many lives. Israel is another good example. In Israel, they were having a lot of suicides in the military, mandatory military service there. People had guns. And so they passed a slew of measures to try to reduce suicide in Israel at the same time. So there was a hotline that was bolstered. They tried to increase access to mental health care among these soldiers, all good things. But one of the things they did is they made it so that when you went home on leave for the weekend, you couldn't bring your gun home. It stays on base, right? After that set of measures, there was a big drop in suicide by 40%. Again, that's a huge drop. Now, it might have been any of these other measures they were doing. However, notably, that 40% drop was driven by a 70% drop in weekend rates specifically. There wasn't really a change on Monday nights or Tuesday or Wednesday. It was the weekend suicides went down, which is when that gun measure might have been most effective. So it's a little indirect to say, but I think that had a huge effect. Closer to home here, bridges are a problem in Washington, D.C. Most of you probably spent some time in Washington, D.C. at this point. There's about 10 high bridges in D.C., but for a long time, the vast majority of suicide by bridge in D.C. was from the Ellington Bridge, which there's just a map here. You see the Ellington Bridge over the Rock Creek Ravine. Ellington Bridge is right next to the Taft Bridge. You can walk, I have walked from the Ellington Bridge to the Taft Bridge. It's like 2 minutes. It's on the same block, basically, over the same ravine. But people use the Ellington Bridge. At some point in 1986, they finally were able to convince the city to put up bridge barriers on this very high-risk bridge. And they put up these anti-suicide fences. You can see this picture here. They're like 10-foot fences with a curve at the top. They're very hard, not impossible, very hard to climb over. And when they put up those suicide fences, it did reduce suicides from the Ellington Bridge by 90%. But what it didn't do was send those people to other bridges. So that's the argument for bridge barriers, right? If we put up a barrier, there's, well, look, the Taft is right there. It's like literally, if you're on the Ellington Bridge, you get there, you see the fence, you're looking through the fence at the Taft Bridge, like not much farther away than like this room. But people didn't walk to the Taft Bridge. There was no increase from other bridges, from the Taft Bridge or any other method of suicide. This is just sort of, you see the dark is the Ellington Bridge suicides. They put up the barrier and that drops pretty dramatically. There's no real change to the Taft Bridge, and then that starts going down as well. And this line is suicides by other methods, also just kind of started sinking and still started going up again when suicides in the country in general was starting to go up again. Guns, every policy we put into place that decreases access to guns decreases suicide pretty consistently. DC started requiring a license to get a gun in '76. And we started to see firearm suicides drop by 23% with no increase in other methods. Dan Webster on my side of town did a study of child access protection laws. These are laws that are good to be familiar with because we have one in Maryland that actually was just sort of bolstered. Ours is called Jalen's Law. These are laws that make it so that if you have a kid in the house and there's a gun in the house, the gun needs to be stored locked up safely. It's one of the ones that some people would call like a common sense gun law. It's like not, it makes a lot of sense. There's a kid in the house, lock it up. But those laws only exist in about half of states. We're one of them. And our law is one that we've actually got a paper under review right now showing our law to be effective in reducing youth suicide. But back in 2004, Webster did a study of child access prevention laws across the country and found that just passing them decreased suicide rates in teens by about 8%. Mike Nestadt and his wife, Joy Nestadt, who was just here yesterday in Baltimore giving a talk for me in my department, have looked at all kinds of gun laws, from background checks, waiting periods, permits. Just about any law that you make that makes it harder to immediately get a gun reduces suicide rates, controlling for other things. Won't go through all of these things. Yeah, skip this. I'm going to quickly mention gun sales during COVID because we've always had a lot of guns in the United States. I think it's about 1.4 guns per person or something. But we had a dramatic increase in guns during the COVID pandemic. People generally saw the New York Times headline in March of 2020 when the pandemic really was first taking hold, saying March of 2020 was the second highest gun purchase month we'd ever had in the United States. The first highest was when Obama had been reelected and there was people that owned guns that were worried that the gun laws that he would pass would make it harder to get guns, so they stocked up, right? But this was the second highest in March 2020. However, as you kept following this over, there was March, but then there was June, broke March's record. July, August, October, November, December, each had over 50% increases compared to previous years. We're easily, every month was breaking the record for the highest month. By January of 2021, we finally crossed the 4 million sales in 1 month sort of landmark, which was a huge landmark to cross in terms of gun sales. But by March of 2021, we were up to 4.7 million in a month. So I mean, really, it's an unprecedented increase. And many of these people were new gun owners. About half of them were new gun owners. People that weren't just stocking up on guns, right? I mentioned the political motivations for stocking up back in 2016. Those are people that already had like 6 guns and they were buying their 7th and 8th. These are new gun owners. In fact, the increase in gun ownership was seen more in blue states than in red states for the first time ever. This figure is just showing the gun purchase rate every 6 months for the last like 20 years, divided into red and blue states. So you see red states tend to buy more guns. That's not a big surprise, including in that big spike I was talking about before. But in 2020, for the first time, we see not only the biggest spike ever, but it's one that's actually bigger in blue states. And there's other studies that have looked at who were these new gun owners. They were a very different type of person than previous gun owners. They were more likely than before to be women, to be Black, to live in urban settings, to live in blue states, as I said. So it's a new type of new gun owners that weren't already sort of gun stockpilers. Lyons did a study to find out who these people were and what the situation was that they were bringing the gun into. Found that about half of these folks had kids in the house, these new gun owners. And remember, this is 2020. So like, you know, those of you that have young kids like I do know that kids in the house meant they were like really in the house and like exploring and going stir crazy, and having a gun in the house was a worry. And about 40% of these folks said that at least one of the guns they had was stored unlocked and just sort of, I guess, accessible. Many of them had mood disorder. Many of them reported a household member with dementia. By the way, you know, overall, forgetting 2020 as an oddity for a minute, the group in the United States that has the highest proportion of gun ownership and going up the most are people with a dementia diagnosis, just because of the demographics that come with that, which is worrisome. If you're treated someone with dementia that still has a gun, it's a scary thing to think about as you discharge them every day. Now, I mentioned this sort of suicide rate went down a little bit, then came up again in the United States. But if you break down that suicide rate a little bit more, it wasn't just that uniformly suicide rates went up in 21 and 22. There were different rate changes in different demographic groups. In fact, over 2019 to 2021, over that period where it sort of dipped and then went up again, overall, non-gun suicides actually went down. There was a decrease in suicides. 8% decrease in non-gun suicides. It was only gun suicides that went up, that drove that whole increase, the highest rate we've ever had. There was just so many gun suicides, it offset the non-gun suicide decrease. And because the guns weren't going into American homes homogeneously, they were going to certain demographics, as I mentioned, we see differences in the suicide rate in those populations. So I had a paper that came out early in the pandemic looking at the suicide rate changes in Maryland specifically, finding that white suicides went down a lot during the lockdown for the pandemic, actually were cut almost in half. Black suicides in Maryland went up almost doubling. This is national data though. National data showed about the same thing to a less of an extreme degree. You see, this is 2019 to 2021, so like over that pandemic year. The white suicide rate stays basically the same. Black suicide rate went from 7 to 8.4 per 100,000. It's a 16% or 17% increase. This is the largest increase in any demographic population we'd ever seen over this time period. That's the population that went up. But if you stratify the Black suicide rate in the United States over those years, you see that most methods didn't go up. Suffocation, poisoning, all others combined stayed about the same. It was just firearms. So it's all stable till 2019. 2020, there's this influx of guns that continues influxing, and you see firearm suicide rates go up specifically. The other thing that was talked about a lot during the pandemic was youth suicide. Youth suicide, again, if you look at, this is suicide rates in young Americans. By most methods, it stays the same or maybe goes down a little bit. But again, firearms, that's what went up in that population. That's what was behind it. Which brings me to something we can do about it. I want to talk to you about red flag laws because Maryland has a unique situation with red flag laws. Those of you unfamiliar with red flag laws, they're also called gun violence restraining orders, extreme risk protection orders. They're the laws that make it so that the police or a family member, or in some cases a clinician, can petition a court to remove a gun from someone who they feel like might be a danger to themselves or others where they'd have access to that gun. So this is like a domestic violence restraining order, right? It can be initiated, a judge approves it, that kind of thing. They go back a while. Connecticut had the first one back in 1999. Their risk warrant sort of was a trailblazer, but then after the Parkland massacre, a whole bunch of states started passing these laws. Maryland was one of them. Nowadays, 21 states and DC have red flag laws. They vary a little bit state to state, and we'll talk about that. But Maryland's was the first one to include physicians, actually really any clinician, as petitioners. So not just the police or family members, but clinicians. Not only could clinicians petition, but arguably it became malpractice at that point for us not to petition. These are laws that are pretty effective. And we'll talk about the nuts and bolts of Maryland in a second, but I will say they've been looked at as far as efficacy. Jeff Swanson did a study a while ago before the massive states started passing these laws, back when it was mostly Connecticut. And he found that for every 11 or so guns seized in an ERPO, extreme restriction order, about one life was saved. That was actually reevaluated just this year. And now they're saying sort of in looking at a different way, it's about 22 guns seized to save one life. At the end of the day, this is the number needed to treat. So it's relevant to us as clinicians. Whether it's 11 or 17, it's another study, or 22, kind of doesn't matter that much, but it's really effective. Aaron Cavisto and this guy over there wrote this study in 2018 that uses a synthetic control model to look at the efficacy of these laws and found that Indiana's version of the law reduced firearm suicides by about 7% over the course of 10 years without any replacement increase in other methods of suicide. And I've got a paper under review right now that show that of the states that include clinicians as petitioners, so it was just Maryland. Now it's Maryland, DC, Hawaii, Connecticut, New York, arguably Minnesota, though is a little bit weird. Of the states that include physician petitioners, there's a bigger effect on the decrease in firearm suicides. There's a 15% further decrease in firearm suicides in those states. And actually, in Black populations, there's a 24% decrease, maybe because of clear reluctance to go to law enforcement, which can be dangerous, and instead go to your clinician. And that might make it more effective to have clinicians as petitioners. Still, most of us aren't using ERPOs. I mean, I'm not going to ask people to raise their hand, but most clinicians, even in a high-risk environment like we're working in, aren't really using them. We'll talk about that. So as I said, Maryland was the first to allow them. Some nuts and bolts of how ours work, because it's available to you guys. Our law can be filed by a family member, a roommate, police, as I mentioned, any kind of police, state police, local police, sheriff's department, a clinician, which means any kind of physician, any psychologist. If you're a social worker, if you're a psychiatric social worker, if you're a nurse, if you're a psychiatric nurse, so not all nurses, or a state health officer, you can file an EP at the same time. It's kind of built in that way. There's like an appendix to the ERPO where you can file an EP, because often you can imagine there's overlap in that population. Filing this does require the petitioner, whether it's a police officer or you, to go to court. So, I mean, deal breaker right off the bat. That's, I think, one of the big problems. But we do have to go to court. The idea is you would file these on a respondent or patient who's in immediate danger to themselves or others, if they were to have a gun, in your clinical opinion. What happens when you file one of these is that the police, a judge grants it quickly. We have, even if it's like midnight on Christmas, there's emergency orders, the judge is contacted, so it happens right away. And once the judge grants it, assuming that they feel like it's worth granting, which in Maryland they almost always do, the police will take away that person's guns. They'll also put them on the do not buy list, so they can't just go and buy another gun. They're on the NICS list temporarily. That lasts for about a week, or for 7 days, after which time, or during that time, there has to be a more final order evaluated. So that second thing, where there's a more formal hearing, due process, the respondent is there to defend themselves, the petitioner is in court, like I said, that has to happen within 7 days. And if that is finalized by the judge at that hearing, then the gun remains removed and they're still on the do not buy list for 1 year, and it can be optionally extended up to another 6 months. So a maximum of 18 months is the last resort. You can file these when there's a child in crisis and the guardian owns the gun. So you don't have to be the gun owner, right? So if you have a young patient and dad has a gun and he's not sort of appreciating the risk to it after conversations. Remember, this is a extreme risk order. It's you've tried other things first. You can file this order because the kid at risk has access to that gun, and that gun they have access to will be taken away from the family. If it's an illegal gun, they won't be returned. In theory, and we've had sort of we had reassurances from Brian Frosch, but we haven't yet had final conversation with Anthony Brown as far as state's attorney. But in theory, when the illegal gun's taken away, there's no charges pressed. They're taken away and they're not returned at the end of that period because they were illegal guns. But the warrant is specifically to remove the guns, not to prosecute for an illegal gun, not to prosecute if they find some heroin on the table, or not that we have heroin here anymore, fentanyl on the table. They won't prosecute for those things. The idea is a very specific, narrow warrant to take these guns out. That's important because you are sending the police into your patient's home, and their mental health is certainly not going to be improved by being in prison. Now, there are other, I should mention also that you can't be sued for filing this. You're sort of protected as long as you file in good faith. A patient can come after you and say, oh, they were just trying to punish me because I didn't pay their bill on time or whatever. You're protected under sort of like Good Samaritan law. You're not necessarily protected for not filing. It's a gray area. No one's actually been sued in Maryland yet over not filing and something bad happening, although it did happen in Indiana and someone was successfully sued. Filing these avoids some problems with the system that we use otherwise. So I don't know about you guys, but if I have someone in the ER or something like that, and I'm really worried about them, maybe not enough to involuntarily admit them, but I know there's a gun at home, I'm trying other things. I'm saying, hey, would you give the key to your gun safe to your wife, or, things like that. And one of the things I'll say is, can you just give the gun to your, brother-in-law across town for a while because you're clearly in a crisis right now, which is technically, it's quasi-legal because they're not getting a background check. There's case law that allows you to use emergency transfers, but it's not quite legal. It also puts the brother-in-law across town in a kind of weird position. Like, when do they give the gun back? Who are they to kind of make that call? Or what if the gun gets stolen or used in a crime or whatever, who's responsible, all that kind of stuff. But it's mostly this idea that you're putting someone, even if it's like, wife that has the key to the lock or brother-in-law across town, they're having to make the decision, make that clinical evaluation. That's rough. That's a rough spot to put someone in. Let's skip over some of the other nuts and bolts of the ERPO, but I will say we're using them a lot in Maryland. Maryland actually has the highest rate of ERPO filing of any state. We don't have the highest number, that's Florida, which surprised a lot of people. Florida uses it a lot, but we use them a lot. However, it's almost always family and police filing these things. Clinicians, even though we were this sort of guinea pig trailblazer with clinician filing, only about 1 or 2% of these are filed by clinicians in Maryland. We were trying to figure out why that was. So early on in the law, when the law had passed, in 2019, we did a study of physicians at Hopkins, just because that's where we were, asking them if they knew about the law or, had they ever used it? Why wouldn't they use it? That kind of thing. We surveyed 92 physicians. It was psychiatrists, pediatricians, and ER doctors. Those are the people that we think are most likely to have patients this would apply to. We found that generally people didn't know the law. And this is back in 2019, but I think still a lot of people don't know about this law. In fact, only one respondent had filed an ERPO at that point. It was a psychiatrist. We asked people how often they saw patients that would be potentially applicable for this, like eligible patients that might have access to a gun. And they said pretty frequently. Many of them said, a couple of times a year at least, most of them said. But then we asked them, well, would you file one of these? And even though they just said they had patients that these would be appropriate for clinically, only about half of them said, yeah, we would file one. So we asked, well, why wouldn't you? The barriers are what you would expect. Well, I don't have time to file this kind of thing, or I'm not familiar with laws. I'm not a lawyer, or the therapeutic alliance, right? Obviously, there's all kinds of risks to the therapeutic alliance when you do anything paternalistic like this. Of course, as psychiatrists, we're used to this a little bit. We sometimes have to hospitalize people. We have to med panel people. This happens. And we do it only when it's potentially life-saving. But still, this is a new thing that we're doing. So there was worries about therapeutic alliance. We said, well, what would help with this? And most of them said, well, if we had some kind of coordinator that would do this for us, that would talk to the patient, fill out the paperwork, go to court, then sure, I'd do it. I don't know if you have this at Maryland, but at Hopkins, we have a child abuse team that is sort of separate than the medical team that's brought in when there's suspicion of child abuse. You see like a spiral fracture or something. These guys come in, it's one pediatrician, 2 social workers. They do their own evaluation. They're the ones that go to Child Protective Services, go to court if they need to, because, the PICU doctors can't do that. They don't have time. So we wanted the same kind of a system for this that would solve the problem. So we did it. We got money from Brandon Scott to create gun violence navigators, safe storage navigators, we keep changing the name, navigators, who are social workers paid by BCRI Because we wanted people that were trained to have these conversations that clinicians could bring in to not only talk to patients about gun safety across the spectrum. Like you got a patient that has a gun, you might, not think they're at acute enough risk that you're going to file one of these. Remember, they're extreme risk factors, but you might offer them a gun lock or talk to them about how important it is to keep the gun stored safely. Or maybe you'd recommend out-of-home storage in someone's a little more acute, or in a very acute case where those things aren't appropriate for clinical reasons, you might file one of these ERPOs. And in that case, the navigator would be the one filing, would go to court. We'll close the loop with you, let you know what happened, but ultimately we'll take control over this. They're employed through BCRI because when we tried to hire social workers through Hopkins, we learned how low Hopkins salaries are and couldn't hire anyone. So we hired through BCRI. It was amazing. Like we were laughed out of the room. So BCRI manages it. You guys know BCRI. They're an important part of our mental health care system, and they're partners of mine on many different projects. So they're the ones that are managing this. They're available to ER doctors, to inpatient doctors, to outpatient clinics. At first, we were only doing this at Hopkins, but we're expanding it to Maryland as of now, which is why I'm here. These are people you can call.
Maryland, the state of Maryland?
Oh, I'm sorry, University of Maryland. Okay. Yeah, I should start by. All right, so let's talk a little bit about that program. So as it's been running at Hopkins for a while. We haven't had very high volumes. We've had probably on average, 1 to 2 calls a week, which is lower than we expected and that we're able to handle. And for that reason, we want to sort of expand as much as possible. So we got BCRI to agree that they would be able to cover also this side of town. There's this flyer. I printed out a bunch of copies and left them at home, but I'll email this out. There's a flyer that sort of gives the basic info, so you could leave it in a workroom or something like that. But it has the phone number to call if you run into a patient that this would be appropriate for. That's the number for Quinita Garrett, who's second in command at BCRI and is managing this project for us. And she's usually, there's 2 social workers, but often she'll be the one to come out and do the assessment. BCRI, if you do call them and ask for the gun navigators, they'll probably want to know a little bit about your patient. I find it easiest just to fax them the H&P, but also maybe give them a little bit of a warm handoff. Do you already use BCRI in your ED when you're trying to send someone to a crisis? It's the same as that. Same idea as that. In fact, if they're in the ED, you might even get your patient data coordinator to do this. That's what we're doing. Yeah, of course.
You don't need a release of information.
No, because they're part of the treatment team. They're part of the treatment team. So it's we actually had our legal team create a new memorandum of understanding with BCRI, not for this, but I went to them to ask that question and they said, oh shoot, we don't have any memorandum of understanding with BCRI. They've been coming to our ER for 30 years. So we had to go back and do that for that. But yeah, no, it's fine because they're part of the treatment team. So it's the same way as when you call them for getting them a crisis bed, something like that. Now, I recommend talking to the patient about this. You say, listen, we talked about the risks that you're at right now, and maybe you have or have not already talked to them about the fact that the gun provides an added risk. I've consulted some colleagues of mine, BCRI, they want to come talk to you about that more. They can do things like make recommendations about safe storage. They can give out gun locks. And I often tell patients in extreme situations, they also have the ability to file this ERPO law, which can involuntarily remove your gun. So, how you talk to each patient about that is clinically specific, right? Different patients or their families about it. But I will mention also that you don't need to hold the patient until BCRI shows up. I know ER length of stays are a thing. You can let BCRI know and they'll follow, if the patient's not so acute, they'll follow up with the patient the next day or the day after. BCRI, they can go to their place of work or home or wherever they have a clinic appointment, they can meet them where they're at. So you don't have to worry about that aspect of it. For inpatients, by the way, what I like to do for inpatients is let the BCRI folks know as soon as I do, like early in admission, that they might be useful, but then don't have them actually come until later in the stay to evaluate the patient for a couple reasons. One is that their risk might change, theoretically you're getting people better. And the other reason is that once they file this, you want the patient to be sort of already have a good enough trust of you as a team that they sort of transfer that trust to BCRI and talk to them more. So you can let them know, but then say, hey, we're probably gonna have this guy for 6 days. I'll let you know when we're like a day or two away from discharge, call you again, talk to them. And again, they can be released, It is actually really useful, just speaking of length of stay, where I was first using ERPOs before this Navigator program was for length of stay. I would have patients on the inpatient unit that I would feel a lot more comfortable letting them go if I knew they didn't have a gun at home, so they could stay in the hospital shorter because they're going home to a less risky situation. Just as you might let them go sooner if there was a good tight outpatient appointment the next day or something like that. Like it's one more thing that can get people out of the hospital faster. Yeah, of course.
Do you have to be a Baltimore City resident or anyone who comes into the?
Oh, great question. So BCRI used to only work with Baltimore City. They've expanded now. They do Baltimore County, they do Anne Arundel and one other county. But yeah, that's an issue. So if the person doesn't live in one of those counties, and BCRI can help guide you. And honestly, call first, and then, and they'll say, oh no, they're off in, Garrett County or whatever, but here's what you can do. The idea is that they're to help you with it. So even if they're not going to, or they're in DC, patients from DC, that's happened a couple of times. But they can help guide you. I want to really quickly mention some other interventions before you get to the extreme end of ERPO. Of course, things like giving patients safe storage methods and encouraging to store safely. This is sort of just really quick sort of a summary of those kind of things. I also want to mention, as far as out-of-home storage goes, a lot of patients that are maybe too high risk to just have it in a safe at home, or like if they're living alone, so there's no one else to hold the key, might want to think about safe storage outside of the home. A lot of family members are willing to do this for patients, but I said there's problems with that. It's not perfect. Law enforcement, certain shooting ranges and pawn shops will hold people's guns in a crisis. Maryland has this safe storage map. You guys can just, instead of copying out the URL, just Google Maryland safe storage map. It shows where there are shooting ranges and pawn shops and other places that have agreed that they're willing to hold someone's gun in a crisis, no questions asked. Now, again, problems with that. They have to decide when to give it back, all that kind of stuff. But these are places that gun owners trust, where they can hold their guns, that kind of thing. I'm gonna skip over some of this just to get to the end, actually, so we have time for questions. I'll just sort of summarize by saying suicide is a leading cause of death. Rates are rising. It can be an impulsive act most of the time. And so people use what they have available. And if they survive, they tend to keep surviving. But if what they have is lethal and accessible, they don't survive. In some places, that's been full gas and pesticide. But in the US, it's guns. That's our leading cause of death. Unfortunately, there's a lot of politics involved in that, like that there wouldn't have necessarily been with pesticides. So we're sort of working around that, but there are a lot of, that means that there's a big role for clinicians to make this into more of a public health issue than a political issue. And we can talk about ways to talk to patients about guns. Screening for firearm access, which the slides I skipped basically showed that we're not screening very well. And advising safe storage, and in extreme situations, filing one of these ERPOs can really save lives. So I want to leave a couple minutes for questions. So that's my talk. Oh, I'll also say, I brought a trick-or-treat bag full of gun locks. So if you guys want these to give out to your patients, there's, I guess, 8 locks in these. Just take them for your units or whatever. So if you have a patient that has a gun at home and they're not storing their gun safely, give them one of those. Yeah.
Thank you. It's a great talk. I was wondering if you could comment on the 988 suicide hotline. Do you have any sense if that engages people who are in that high risk state, or because I found I'm a child psychiatrist, so I give that to every young adult and teenager, and what I found is that I can engage a family member or a friend to call, but not so much the young adult or the teenager to actually call during high risk state. So I'm just curious, does that actually attract people at a higher?
So yeah, it's a great question. So I have to admit some bias. So 988 is the face of suicide prevention right now in this country, and it's where the funding goes. And BCRI runs it for Baltimore, and they're good partners of mine. There haven't actually been good evidence that it prevents suicide death. People are willing to call. There are people that are willing to call. There's also sort of a backlash where there's a movement to dissuade people from using 988 among the patient population, lived experience population, because of worries of paternalistic calls where they might have the police come and bring them to the hospital, which arguably is life-saving, but also can be traumatic. So it's complicated. I'm in the process of putting together an alacrity grant, a center grant, to help 988 with this. So I feel like I shouldn't comment too much, but I think that right now it's not doing as good as it could be doing. But if your specific question is will it attract high risk people? I think there are people that will call, but most people who are very high risk are probably not calling them. They're also not coming to us, unfortunately. That's the thing about suicide, is that we are really bad at detecting suicide, and people, which where our risk assessments are terrible. And the people that are at high risk are rarely coming to care. Not necessarily because they're scared we're gonna do something bad to them, but because they're just unaware of it. The way I would think about suicide, and I just as an overall thing, is as a public health issue where universal prevention strategies are always gonna be more effective because we can't do selective strategies. For instance, car accidents. That was the public health issue when I was in med school. That was the leading cause of young people death when I was in med school. And we brought those car accident deaths down dramatically now. Now suicide's overtaken them. But we did it not by identifying people at risk, like doing reaction time tests on everybody before they got a license and saying you can't have a license if your reaction time's over this, or if you got into one fender bender as a teen, never letting you drive again. We did it with universal prevention. We said everyone gets an airbag. Every car has seatbelts. Every highway has a maximum speed limit of 65 on the federal system. Those things are how we did it. Universal prevention. They didn't really reduce car accidents that much, but they reduced car accident fatalities dramatically. Those airbags hit. So same with suicide. We don't know, we really don't know who's going to die by suicide. This ERPO is one way of addressing people when we really do know in those extreme situations. But in general, we're going to do a lot better with universal prevention. Airbags in every car, gun lock on every gun, that kind of thing. Population level things are how we're gonna win. It's also with smoking too. I'm like, every time we've had a major killer, once we start seeing it as a public health issue, we address it with policy that are universal, and that's, I don't know how I got to that topic, but I think that's an important thing to note, and that's why I think this is useful. Yeah.
Thinking of the fact that we're very bad at predicting who we're going to attempt suicide. I guess there's an article that came out relatively recently looking at like EHR data and developed this like suicide risk score. Yeah. Which I think immediately built, but I don't think they've implemented yet. And I'm just wondering what you think about like having the suicide risk score available to all physicians. Yeah, that's a great question. And you guys work at the VA too. So you know there's ReachVet, which has that already in their EMR. So our screeners are not good. Our screeners are based on suicidal ideation, you know, and that's why they're being listened. And we're the only country that still mandates those, by the way. It's because Columbia makes money from the Columbia screener. But the screeners aren't good. So in theory, these things using machine learning, these big algorithms, and I'm part of a project doing that too. We have something called the Maryland Suicide Data Warehouse where we're trying to use algorithms to predict suicide. They're a little bit better. AUCs in like the 0.85 range. Again, they're not great. And even when you've identified someone, what do you really do? I think the VA is struggling with that. They have these teams, but they don't. So I think it's great. And I think they should continue to be developed. As we get more and more data harmonization, so these big data sets, then maybe we'll have this magic black box that you feed somebody, but we're not there yet. So I don't want to say they can't hurt, because just like screening, there's tremendous amounts of false positives, which can have, you know, bad consequences, people getting treated, but there's also a lot of false negatives. I mean, my suicide fatality review team, we just reviewed our first case last week, and it was a 76-year-old man who had gotten a PHQ every time he'd seen his doctor, which was approximately monthly for like a year. And, you know, negative with that suicide question. And then 2 days after his last PHQ, he killed himself. And that doctor, maybe if they hadn't been seeing all these negatives, would have noticed all the very clear clinical warning signs this guy had. Chronic pain. He had all the signs of depression his wife was reporting. But these things are like, oh, check that box, we're good. And I think that those algorithms will have the same thing. If you start to have a red flag that pops up for a high-risk suicide person in your EHR, every time you don't have that red flag, not psychiatrists, but other clinicians don't have that red flag, they're maybe not going to be thinking about it at all, because that's taken care of. Yeah.
You mentioned one of the biggest barriers with clinicians filing ERPOs is the court hearing. Are they doing that virtually?
No. Well, okay. For a while, some counties were, but now not reliably in any way. And the other thing, sort of the sister to that question, is administrative judges aren't doing it either. So, you know, we have the administrative judges for our hospital. That would be great if when you had the admin judge come in for your certifications, if they could also do that. But no. So you generally have to go in person, which is why the Navigator system is really the only way to make clinician filing work. Outside the Navigator system, you could do things like, and we used to do this a lot, contact the police, say, I'm worried about this guy, can you file? Contact a family member. Police, it's hit or miss. Like the police in Baltimore City have been a lot less willing to do this than in other counties. The police on the west side I've found to be more responsive than the ones in my district, Southeast district, they won't even bother. But the west side, sometimes they'll do it. Anyway, so there's other options. But yeah, ultimately, if you're the clinician filing, you have to physically go to court, and you don't have time for that. Any other questions? Yeah.
I don't know, or comments, or I don't know if you have any thoughts like, about the whole idea with ghost guns and obviously a lot of people do the tracking and
Yeah.
buying guns and background checks, but like can 3D print guns and whatever they want these days. I don't know if this has changed like the metrics, how people look at it or.
So ghost guns are a problem that this doesn't help that much with. I mean, obviously, the nice thing about this is that you get the guns taken away, whether it's a ghost gun or not. The police are searching the house for guns. But yes, they could print or buy another one. Ghost guns are a major problem that is one way around this. However, it's the same way as having to buy a second bottle of Tylenol, right? Like, yes, they could, even if they're forbidden from buying a gun, they could order 49% of a gun from this place and then buy the firing pin somewhere else. But it's just one more barrier, just like, having that fence. So I think it's still really effective. And of course, this is Baltimore. You can also buy guns illegally, even if they're not ghost guns. But yeah, it's a good point. It's a problem. Actually, Mark, let me get your question. Then I just realized there's a bunch of the chat that I didn't see. No, one second.
So this, I just lost it.
Okay, I'll give you a second because I'm just seeing. I'm not going to scroll all the way up, but I will in a second. But Vice Postalach, who's a suicide researcher who I have great respect for, says, "Great position in key effort. How do you explain the increases in suicide rates in the U.S. relative to other countries where they are by and large decreasing, in particular countries with similar gun availability?" So the question is, how come the U.S. is going up? I showed you this U.S. rates, whereas the rest of the world is going down. Suicide is multifactorial, obviously. There's all kinds of factors. I know I've been really focused on guns. There's lots of factors. So for instance, you have a country like Japan, where there's not a lot of guns, but there is a lot of suicides. And maybe in that case, the situation is more about cultural appropriateness or acceptability of suicide. Or you have Korea, where there's a lot of suicides that's more in urban areas than rural, which is the reverse of what we see everywhere else. And that's because in Korea, there are these tall buildings in urban areas. And so that ends up being, it's a major factor. So it's always different factors. So Tio's question is, how come other countries are going down when we're going up, even countries that have guns? I think that there are virtually no countries that have anywhere near as many guns as we do. I mean, even a country that has the second highest number of guns, it's the minority of people that have guns. So it's almost one of apples and oranges as far as the ubiquity of guns. So that's one aspect. But then the other part is there's lots of factors. So you want to do something like Peter did, like a synthetic control model, where you try to get everything else that you playing into it evened out, and then see how the gun factors in. That's what Matt Miller did to look at the country. But you could do that globally, theoretically, although I haven't seen someone do it yet. Yeah, Mark.
So this is being funded by the mayor's office.
Yeah, so far.
Correct. So I don't know how long we're talking about, whether it will continue. And I guess just to throw out, I guess it's a policy idea is, when they opened up the casinos, there's this gambling money that comes to help protect gamblers. Should there be taxes on guns to fund this program?
I mean, that question's above my pay grade. I will say that, so Monsi, the mayor's office, paid for it at first, and they kind of have just kept renewing it. But at this point, the social workers are trained and BCRI is kind of committed to it. And it's not that heavy of a lift to just add this added job to the already existing sets of jobs. These social workers are also the ones going out of mobile treatment teams. They're also the ones that are coming to your ER. It's just now this is another role they have. So it's not that big of a ask. The other thing is that it started with mayor's office funding. We've actually got some other funding now too, because we've got a separate grant specifically to evaluate this from the CDC and another one from AFSP. There's lots of other funding sources, but we want it to be sustainable. One nice thing, and this is news that I just saw yesterday in that, that giant psychiatric services newsletter that comes that we never, so on the front page yesterday, CMS has proposed us to be able to bill for safety planning. And safety planning, which is a great intervention for suicide prevention, snuck in safety plan is step 6, right? Which is secure the environment, right? So that last thing in the safety plan has all that stuff about make sure there's no guns around, lock the guns up. So the BCRI guys, I don't know how much they're going to, reimburse, but it's billable now for them to do that. So they can be brought in to bill for safety planning, and this would be part of that. So, I mean, that's the only way to make these things sustainable is when it's billable. There's also, by the way, you probably already know, you can bill for suicide screening, you can bill for depression screening, you can bill for substance abuse screening. Those things, I don't know how much they've moved the needle on people doing those services. I think they have more in non-psychiatrists than in psychiatrists, but theoretically, we could use that billing model to make this more sustainable and self-sufficient. Yeah.
The BCRI team, so I'm a consult psychiatrist, I primarily work in trauma. will they come see med surg inpatients?
It's a good question. I don't see why they would. Oh, wait, sorry. I'm sorry. Yes. We had someone on the consult team call. They ended up not filing the ERPO.
Yeah, that was Midtown a couple years ago.
No, I mean, we had someone at Hopkins. This was a guy who had actually, this is a terrible story. He had actually no psychiatric problems, but he was a gun instructor. He trained people on safe gun usage for a living. And he was trying to impress a girl, and he was showing her how the safety is on, and he literally blew his jaw off. This guy trains people in gun safety. So the one thing you'll say is don't ever, whatever, anyway. So Avi on the consulting talks to me, we get PCRI to talk to the guy. Really, it was more of like a, have you learned your lesson finger wag? And they're like, yeah, there's no reason to ERPO this guy. Like he's not at risk. He's not going to do this again. So they didn't filing, but yeah, he was actually still in surgical recovery. So but it might depend on your deal with the hospital. So if they're not allowed on there. By the way, they can also do it over Zoom. They can do it over Zoom. We've had them do it over Zoom a few times. I think I might be out of time, but if anyone had, I'm way over, I'm sorry. Any other questions, please just email me. I see there's ones in the chat that I didn't get to, which I'm trying to find the mouse, but I'll just email me if you're. Oh, it comes out to walk if you want. Yeah, and I've actually, I got. Because I.
We'll send that flyer.
Yeah, I emailed it to your ER folks, but I'll email.
Email it to like, Chris, and we'll send it out to everybody.
Yeah.
Chris,
Yeah,
Lorraine, just send it to him and we'll email it to everybody. Couldn't move the damn arrow with.
Yeah, I wasn't looking at the chat enough. I forgot.
That's all.
Anyway, that was wonderful. Thank you for
Thanks.
coming. I thought it was better if you'd talked to the whole department.
Oh, absolutely. Yeah.